Hello, and welcome to the first web broadcast of this year's Community Knowledge Network Education Series, brought to you by the Vizient HIN. That's Hospital Improvement Innovation Network, the HIN. Today's program will continue our examination of a very potent issue in healthcare, and that is how to care for the caregiver after an unexpected or traumatic event in a healthcare setting. We're focusing on the impact these events have on healthcare workers. Events such as preventable harm, a patient death or setback, or anything that's emotionally traumatizing to staff. Too often, trauma affects healthcare workers who are then forgotten. They're left to deal with the difficult event and the psychological aftermath on their own. Today, two experts from MedStar Health are here to discuss their commitment to building a successful Care for the Caregiver program. We'll examine the details of their program, discovering the value they've found and the results they've experienced. I'm Marty Hatley, President and CEO of Project Patient Care in Chicago. I'm also Director of the MedStar Institute for Quality and Safety, and I'll be your moderator for today's program. We're broadcasting live from the Vizient studio in Irving, Texas, and we're very glad you're with us. So let's get started.
For disclosure information, please refer to your program supplement.
Before we begin, let's review our learning objectives. After viewing this program, you'll be able to describe the impact adverse events have on resilience of a care team. You'll be able to explain the key aspects of CANDOR, which is an acronym for Communication and Optimal Resolution, as it relates to caring for the caregiver. You'll recognize the value in an organized approach to providing support to caregivers in need, and determine the tactics required to establish a Care for the Caregiver type program in your organization. You're an important part of our program and we want to hear from you. There are two ways you can join us. First, chat with us online. If you're watching on the web, send us your questions or comments at any time. Just type your message and click submit. You can also email us at vizientvideo@vizientinc.com. Whatever is easiest for you, just join the discussion. And now let's meet our special guests. First, Dr. Lisa Boyle. Lisa, briefly tell us about your background and why you've joined us today.
Marty, first of all, thank you so much for inviting me to this very, very important discussion. I'm a surgeon. I've been a surgeon for about 30 years, and I currently am the Vice President of Medical Affairs and Chief Medical Officer at MedStar Georgetown University Hospital. I've been with MedStar Health for 24 years, the last 4 of which in this capacity at MedStar Georgetown. In my role, I oversee the quality and safety initiatives for MedStar Georgetown. And as the Care for the Caregiver program is one of our initiatives, I oversee that program for Georgetown.
Thank you, Lisa. I'm delighted that you're here with us today.
Thank you.
And now it's my pleasure to welcome Tim McDonald, a close friend of mine and colleague of mine. Tim, tell us a little bit about yourself.
Well, thanks, Marty, and it is a pleasure to be here with you and with Lisa. I'm so honored to be sharing this these moments with her and also with our audience. I am a physician, but also an attorney, and I've practiced anesthesia for 25 years before I retired from that to really focus on patient safety activities, which have been my passion for the last 20 years or so. I've been at that brutal interface between patient safety and medical liability and have really been honored to be the lead in some important projects in the country, including the creation of the CANDOR Toolkit. And importantly, it includes one of the topics, obviously, we're speaking about today, which is the Care for the Caregiver component. I've recently taken the position as the director for the Center for Open and Honest Communication at the MedStar Institute for Quality and Safety, where I work with Marty. But I've also been able to work with multiple hospital systems and liability insurers nationally and internationally, including, importantly, one of the most innovative insurers in the country, which is the Beta Healthcare Group, where they are helping their members implement their Candor program, and it includes the care for the caregiver.
Thank you, Tim. We've been trying to get you on a program like this for a while, so I'm very glad you're here. Lisa, let's take a look at the traumatic effect adverse events can have on clinicians. Why is this aspect of our patient safety work so often ignored?
Well, Marty, that's really a great question and really foundational to our discussion today. Much of what we do in healthcare really involves high-risk activities. And our healthcare systems include real people, human beings, that make mistakes. And unfortunately, these errors may harm our patients. And these events take a tremendous emotional toll on our caregivers. And unfortunately, if we're honest with ourselves, the culture in healthcare has been one of blame. And we really need to flip that. We need to flip that discussion and really provide for our caregivers support and guidance when they need it most to prevent their suffering in silence.
Thanks, Lisa. Yeah. Now, there's a concept in this work called the second victim. Could you walk us through that concept, describe it a little bit for us?
Yeah, sure, Marty. So when we look at harm events, and these are serious adverse events that affect our patients, we really think of there being three victims in these events. The first victim, obviously, is the patient and their family. But there is this concept of the second victim. And when we say second victim, what we're really talking about are the caregivers, those that are directly involved, and then the team members that are indirectly involved in the care of the patient that may ultimately lead to harm. And then there is, of course, the third victim, which is the organization and management, which are also affected by these events. I'd like to quote for you Dr. Albert Wu, who's the Director of Healthcare Policy and a professor at Johns Hopkins University. And he's described second victims as healthcare providers who are involved in an unanticipated adverse patient event, in a medical error and/or a patient-related injury, and as a result become victimized in the sense that the provider is traumatized by the event. Frequently, these individuals feel personally responsible for the patient's outcome, and many feel as though they've failed their patient and unfortunately begin to second guess their clinical skills and their knowledge base.
Thank you, Lisa. How frequent, how extensive is this phenomenon of the second victim?
Well, unfortunately, it's all too common. I'd like to bring to you some information that came out of the Missouri healthcare system that reported that 1 in 7 clinicians had reported that they had experienced a patient safety event within the past year, and that had caused personal problems such as anxiety, depression, and unfortunately, and these are extraordinarily capable people, concerns about their ability to perform their jobs. And unfortunately, in over 2/3 of these cases, Marty, these clinicians reported that they had no support from their institution. I want to bring an actual example to give a face to this problem. And I know that this is a case that many people are aware of. It occurred in 2010 at a very, very respectable university hospital that involved a clinical nurse named Kimberly. She had been almost 30 years a nurse in this organization with impeccable record. And one day she accidentally gave a child a fatal overdose of a medication. And as a result, the organization that she worked for and had been with for 30 years not only placed her on administrative leave, but soon dismissed her from the hospital. Shortly thereafter, the state took action against her license and she was unable to practice medicine. And unfortunately, shortly thereafter, she committed suicide. Another example that I want to bring to you, and this I think many of you may have seen, this really went viral last year. And this involved an ER physician who had just lost a patient, and it wasn't due to error. There were no adverse events. This was a trauma victim, and despite heroic efforts, the patient lost his life. Afterwards, this photograph was captured by an EMT that just happened to be standing outside in the ambulance bay, and he caught the physician on camera weeping, crouched down and weeping after the loss of his patient. This picture went viral, and with it, and the physician asked to be remained anonymous, he he stated this quote, and I want to read this to you because I think it really emphasizes the traumatic impact that these events have on our providers. He said, "And in the end, when the life went out of him and my hands could no longer work, I left that place into the night and I wept. For myself, for life, for the tragedy of death's coming. Then I rose, walking back to the suffering house, forgot again my own wounds for the sake of healing theirs."
Thank you, Lisa, for sharing those really powerful examples and quotes, and for making the point that this is not just about medical error. This is about any event, many events that can create trauma in healthcare. Can you walk us through some of the signs of trauma? What does it look like?
Yes, yes, thanks, Marty, for that question. So unfortunately, these sorts of traumatic events can exhibit a number of both physical as well as psychological symptoms. Some of the physical symptoms, for example, sleep disturbance, headaches, fatigue, muscle tension, and psychological symptoms such as grief and remorse, self-doubt, frustration, the feeling of isolation. And unfortunately, and these are, again, many very experienced providers really feel uncomfortable at the thought of returning to work.
Thank you, Lisa. In the following video clip, we're going to see some of what Lisa was just describing for us, the traumatic effect a medication error had on a nurse and the response of MedStar Health. Lisa, could you set this up for us a bit?
Yes, so the video that you're going to see is a real-life example of what we're talking about. And this particular event occurred at one of our MedStar facilities, right at the leading edge of when we were beginning the implementation of some of these projects. So in my heart, I know that would this event happen today, it would be handled very differently.
So this was a learning experience for the MedStar Health System on their journey. Let's take a look.
Patient care technician came to me and she told me, "I need to let you see this screen." And she showed me the glucometer.
She saw the word high flash on the screen, and that's what she assumed was the result that she had.
She's like, "I just feel like my blood sugar is really high." She's like, I don't feel good. I know my body.
And so there wasn't really any suspicion that it would be low. And so when this error message comes up, it kind of confirmed that.
So we rechecked her blood sugar and the same thing popped up. So I covered her with some insulin and I called the physician. And by the time I got her back in bed, she became like non-responsive.
Ended up being a rapid response and requiring a transfer of the patient to the intensive care unit.
Nurse had misread the glucometer and called the physician, asked for insulin on multiple occasions, and the patient had a severe hypoglycemic event and had to go to the ICU before it was caught.
During the rapid response, we checked the glucose twice, I believe, and the same thing kept popping up, the screen that said glucose greater than 600. The next day is when I received the call that the whole time her blood sugar was actually critically low.
Shortly after this particular incident, another nurse made the same error where the machine it was an actual low value, but the machine read off this alert saying for a high, do X, Y, and Z.
It never came to mind that the glucometer was incorrect. It was probably the worst experience I've ever had in my professional career.
The nurse manager called our human resources department, explained the error, this is what happened. We didn't fully understand the ramifications of this piece of equipment and the message that it displayed. And they said, well, I think you need to suspend her until an investigation is completed.
I felt like I was talked to like a 5-year-old. I wasn't talked to like an adult. I mean, I'm a nurse because I come to take care of people, I come to do my job. I'm very passionate about what I do. And for a long time, it really shook me. Like when I came to work, I was scared to take care of patients, and I was really apprehensive about everything I was doing. I wasn't really confident anymore. It really shook me to the core.
I questioned it with my boss, and she had the suggestion to invite some of the staff from the Human Factors Engineering Department in MI2 to come over and help us at least evaluate the process.
I got a call from the chief nursing officer at one of our hospitals saying that they had a case. There was a design issue that might have contributed to the case, and they wanted us to take a closer look at it from a human factors engineering, safety engineering standpoint.
It quickly became apparent that there was more to the story than just that she had made a mistake, and that there was a lot more, that it wasn't just her. It was the actions of lots of people that led to this hazard, and it certainly could happen again.
You can't fault any one individual. That's a process problem that needed to be addressed. And the more we thought about it, the more we decided that we needed to fix the process.
The concept of high reliability, the concept of systems problems versus people problems, the concepts involved in human factors engineering. They become very familiar to us, those of us who are talking about them all the time. They're not as familiar to the people on the front lines. Our job is to be able to share that in an effective way, one in which they can actually use the tools and change outcomes.
The leadership, when they saw our analysis of the case, they supported the fact that Annie should not have been disciplined, and they reversed the discipline. And that was doing the right thing. And I think that sent a very important message to the staff at this hospital, that the leadership supports them and takes the systems approach to managing error.
There was a team there, and they were all like nodding, and they were all like validating. They were like, okay, so you know, you're not incompetent. Everything you're saying makes complete sense. And it was just like, it's like I could take a breath and be like, okay, I'm not crazy. And then when I was told by my manager, she pulled me in her office after it, and she was like, we're gonna take away the discipline. She was like, they actually said that we didn't treat you so fairly, and that made me feel better, and that was like a positive aspect of the experience.
We need everybody in our system, actually everybody in the healthcare industry nationally, to understand the systems approach and understand just culture, so that when we have near misses and when we have small little noticed hazards and unsafe conditions that we encounter day to day in our job, that we report it and that we look for trends, and where we can, we fix the system so that the next time that same error or near miss happens, we won't injure a patient.
So that video we call Annie's Story. And Tim, you wanted to share some thoughts about Annie's story.
Well, I did, Marty, and I appreciate, Lisa, what you mentioned related to, in your heart of hearts, that sort of disciplinary response would not happen if it happened today at MedStar. But there were some things going on then that are in the video that I think is really important for members of the audience to recognize. And that is that for a long time, MedStar's been known for its National Center for human factors, and they did a lot of great work using human factors in that case. And so it really stands for that. And also, what I saw is a just culture approach to the particular case that involved Annie, and the way that at the end of the day, they did get it right, and they treated her fair as it relates to what happened.
Okay, thank you, Tim. Now, we've mentioned the Candor Toolkit. Tim, can you describe the entrenched problem the Candor Toolkit was developed to address?
Well, certainly, Marty. I mean, as we know, in 1999, when the IOM report came out, it talked a lot about the many, many deaths every year that result from preventable harm, preventable errors that have happened. And then recently, just in 2016, Macri and others at Hopkins, published their article showing the fact that medical errors or preventable harm is now the third leading cause of death in the United States, right behind cancer and heart disease. And that's a really important issue for the country, actually, and internationally, the patient safety problem. But we haven't done as good a job as we could responding to harm, because what also is well known, all too often, when these things happen, we build up a wall of silence. It's a wall of silence between us and patients and families, but also, as Lisa described, the wall between those of us who could support caregivers and who have not heretofore until the Care for the Caregiver program was created. That book was written in 2003, The Wall of Silence. And what it really demonstrates is, despite all the strategies since the IOM report, we've really learned that culture eats those strategies for breakfast every single day. So the Candor Toolkit is really looking at how can you help your organization develop a full culturally transforming process to really address patient harm and learn from it.
Okay. And the toolkit is relatively new. It was published just last year. Can you help us understand how it's different from other approaches that we've seen to these kinds of issues in the past?
Well, sure. So it is fully comprehensive, and it was released in May of 2016. The funding that came for that, and in fact the oversight of it, and a lot of credit needs to go to the Agency for Healthcare Research and Quality, AHRQ. They really helped fund this work over the last several years. And there's 5 bundles that are related to it, Marty. So it includes how do you identify very early on that something's happened in the organization so you can activate the candor process, including the care for the caregiver. We describe it sort of as that process to hug and love patients and families as well as caregivers through these events. In a way, as we saw in the video from Terry Fairbanks, the human factors analysis can really go into that and really look at how do we really redesign the care that we provide. And ultimately, the final piece is resolution, which is often learning. It's a promise to patients and families that these sorts of events won't happen again. And if need be, and our care has been deemed inappropriate or not meeting the standard, come to a rapid resolution financially with those patients and families so they don't have to sue us to get answers to questions or come to that resolution. The key thing we learned from patients and families and caregivers, sadly, is that every hour that goes by without effective communication following one of these events is another harm. So it's critical when organizations begin to roll this out that they have that sort of rapid response process.
Okay. So what have we learned from the testing, the implementation, the development of the Candor Toolkit at MedStar Health and the other systems that you've worked with?
Yeah, so it really requires, Marty, a full paradigm shift. And that means from top to bottom. From the minute the event happens until full resolution, it's a total paradigm shift. So it means rapid reporting of events. It means reaching out to communicate to patients and families right away. And importantly, in the care for the caregiver domain, that, as we'll hear from Lisa, how important it is that we respond right away and we're supporting those caregivers as quickly as it happens. Whereas in the past, the old paradigm was we weren't supporting the caregivers when these things happened. They suffered in silence. They really suffered from the wall of silence that we had built around everybody.
Yeah, great. Thank you, Tim. And we're also kind of connecting this to things that we learn from other industries. You've got a story about Sully that you want to share with us.
Yeah, well, I mean, it's just a great article. I mean, seldom in JAMA do you see titles that are just so fantastic. The title of the article is What I Learned from Captain Sully. And it's written by an anesthesiologist, and she describes what she learned from him, which is that in aviation, they have been providing support to their people for a very long period of time. So if a crash happens or a mishap happens, they're in there right away supporting them. And so she describes that we need to do more of that in healthcare. Provocatively, the other thing that she mentions is that imagine me as an anesthesiologist or Lisa as a surgeon, and we're in the operating room and our patient passes away in the operating room. Well, think about the next patient. You know, do we have an obligation to tell the next patient or family, you know, it's not been a very good day, we've had these events happen, and you need to know we may not be fully on our game. Very provocative, fantastic article. I recommend it to anybody who's interested in the Care for the Caregiver program.
And again, a nice insight into the trauma that just happens, you know, as we do our work in healthcare. Lisa, let's get back to the second victim. What do second victims need in terms of support?
Well, Marty, I think we as leaders in healthcare need to, first of all, accept the fact that we have a responsibility to provide this support, this emotional support to our caregivers in the wake of a traumatic event. I think Tim's comments, and it is provocative, but the suggestion that potentially we provide a timeout from clinical duties after one of these harm events. The other element that Tim touched upon was transparency, and we really have worked very, very hard in our event response program to develop a transparency and communication with patients and their families. But just think about it. You have a provider who's just gone through a traumatic harm event, and then we turn around and ask them to talk to the patients and families. So one of the other elements of our program, which has been very, very successful and really, really critical to our success, is developing a separate team of providers who are trained and experienced in communicating bad news to patients and families. So this is another support tool that we provide to our associates in the aftermath of these harm events. But most importantly, and last but not least, we need to make sure that these associates realize that they continue to be a trusted member of our care teams.
And so this kind of care takes a formal program, and that's what you've instituted at Georgetown, Metro Georgetown.
Absolutely, and it really has been foundational to our quality and safety program. We call it our Care for the Caregiver program, and it is in parallel and in a companion program that we call our Patient Family Communication Service, and the two teams pair together to help support our caregivers in the aftermath of a traumatic event.
And these are both components. It's the Care for the Caregiver, communication with family, both components of the toolkit that you mentioned, Tim. And there's some new research you want to share with us.
Well, there is, and again, through funding from AHRQ, we were able to look back at 13 years of data at the University of Illinois, where we looked at 5 years before and 8 years after the implementation of this comprehensive response to patient harm that includes care for the caregiver. And the data was important for us to see. Number one, which is being open and honest with patients and families does not necessarily lead to increased costs with liability. In fact, we found the opposite. We saw claims go down, we saw the costs go down. There was substantial savings when it came to that. But as importantly, we saw improvements in other activities, including event reporting, event analysis, and all that. But from the Care for the Caregiver standpoint, the most important data is that the time to closure, which is when you have a harm event and then you end up having full closure of that, whether it's you explain to the family care was okay or ultimately you financially resolve it, we saw that go from over 5 years until the time I left the University of Illinois down around a year. And that means 4 less years of suffering of patients and families as well as caregivers having to relive these events over and over again in their mind, but also at depositions. And so again, huge positive impact that we saw in the data.
Thanks, Tim. And we're going to now show you another video clip that really brings to life what Tim and Lisa have been sharing with us today. It's a compelling story that's actually part of the Candor Toolkit about the emotional impact when an unexpected event occurs. Let's take a look.
I have a beautiful blonde hair, blue-eyed 9-year-old daughter who is a quirky little girl, contagious laugh, funny, avid reader, and she was a blooming artist and an athlete, and she's no longer with me anymore. She died of medical errors. She got a hospital-acquired infection. She was a classic case of failure to rescue, where all the signs were there and that she was deteriorating and no one did anything.
At any one time, 1 in 25 hospitalized patients has a healthcare-associated infection, or HAI. About 75,000 hospital patients with HAIs died during their hospitalization. In the case of Carol's daughter, Alyssa, the hospital's response was less than optimal.
She was in a teaching institution where the fear of hierarchy was there, and the resident didn't go up the chain of command. The organization where she died shut down on me. They wouldn't talk about what happened. They would not give me her medical records. It took the organization where she died 3 years, 7 months, and 28 days to have a conversation with me.
The current system doesn't work well for patients or providers or hospitals. When harm occurs, the strong tendency for hospitals is to disclose as little as possible about what's happening.
For Dr. Heather Farley, being forced into silence in another case made her question her ability as a healthcare provider and nearly ended her career as an emergency room physician.
I remember the day really clearly, even though it's several years ago now. I remember what she looked like. I remember the sound of her voice. She came in saying that she was having some palpitations. And it's a very frequent complaint that we see in the emergency department. Did a full physical exam, and we put her on the monitor, and we did a whole bunch of blood work on her, an EKG, X-ray, pretty thorough workup. And by the time that I saw her, she wasn't having any symptoms at the time. I discharged her and I didn't think anything more about it until the next day.
The patient went into cardiac arrest on the drive home from the hospital. She was resuscitated and admitted to the intensive care unit.
I was sitting in my office checking my email, and my administrative assistant called across the hall and said, "Hey, did you know that patient that you saw yesterday? She ended up coming back in." And my heart sank.
Dr. Farley's first instinct was to visit the patient in the ICU and talk with her family.
And everybody that I talked to said, I don't think it's a good idea if you talk to the family. And I just wanted to tell them what I knew, and because I knew that they were suffering and I knew they had questions, and I just wanted to reach out to them, but I never got the opportunity to talk to them, which is something that I regret to this day.
The patient later died in the hospital.
Several months later, I was notified that I was being sued, which is the first time that had happened in my career. I know that I'm a good person and I care about my patients and I work hard, and to have someone there accusing you of not caring, of being a bad physician, of being incompetent, it just strikes so deeply. Most emergency physicians, there's a high percentage that are sued at some point in their career. I knew it was probably inevitable, but it doesn't make it any easier.
I'm sure you'll agree those are very, very powerful stories. Again, those videos are part of the Candor Toolkit. Lisa, can you take us into the Care for the Caregiver program that you've actually established at MedStar? How does that work?
Yes, sure, Marty. The Care for the Caregiver program that we've put together at MedStar Georgetown is comprised of a team of volunteers from a variety of disciplines. We really reached out across the campus. And these folks come together, they receive rigorous training in crisis support and stress management. As I mentioned, the team is multidisciplinary. It includes physicians, nurses, respiratory therapists, social workers, chaplains. It's available 24/7. We've implemented a number of trigger mechanisms. We have a pager, we have a hotline, and we really have worked very, very, very hard to really hardwire this into our safety program at MedStar Georgetown.
Sounds impressive. Now, what would you say to our readers or to our viewers is the core purpose of the program? What would you say there?
Yeah, if I was to say the core purpose really is to provide consistent, targeted, hospital-wide guidance and support in the aftermath of a traumatic event. In addition, we realize that the ongoing needs of our associates after these events really require the management team to be able to handle. So we provide additional resources to the management team in order to effectively support associates in the time following these events.
Okay, and can you walk us through the specifics of how you effectively support associates?
So first and foremost, what we want to do is to provide caregivers with a safe zone where they feel empowered to express their thoughts and their reactions to help enhance their coping. We want to ensure that, to the extent that we can, that the information is kept completely confidential. This is really a one-on-one peer support, really in an effort to explore the associates' reactions and feelings that often occur in the aftermath of a stressful or traumatic event. But most importantly, at its very core, we want to provide that associate the comfort that they need to recover from the aftermath of these events.
So the communication that happens with the caregiver as this component of the Candor bundles is different from the conversations around event review and investigation. Is that right?
Yes, yeah, that's correct, Marty. And if we think back to Tim's 5 bundles of the Candor Toolkit, these elements are really conducted in parallel and do have some connect points, but are very separate. They have separate purposes and they're separate teams, separate skill sets. So the event review process is really running in parallel to our Care for the Caregiver. So really what we want to do is we want to create those connect points. And you heard in both of our videos, and you'll hear in some stories, that one of the fears is that that our providers in the aftermath of these events feel isolated. You hear that word a lot, isolation. So what we want to do is create human connect points. And our team members, our Care for the Caregiver team members, are really trained, and we equip them with the skills to watch for any signs and symptoms that we may need to actually escalate the support.
And Tim, you want to comment on this as well?
Well, yeah, Marty, I think, as Lisa said so well, it's really important to separate out the event review, which has its own process, even its own legal protections in terms of how that's done, versus Care for the Caregiver, which should be focused on the emotions. It is not focused on the facts. And so, in fact, Marty, when we do training of 2 organizations of how to do this, we train people how they are able to stay away from the facts of the event that happened and keep that person focused on their emotions, and how the person providing the support can help them through this, not by dealing with the facts or the rest of it, but purely dealing with the emotions that have resulted from whatever tragic or emotional event they've been involved in.
And Lisa, you've mentioned the importance of the way you carefully picked the members of this Care for the Caregiver team. Will you tell us a little bit more about that?
Yes, I think in large part our success has been in the implementation of the Care for the Caregiver program. So as I mentioned, it's a multidisciplinary team. We handpicked them, and we looked for certain qualities and characteristics that we think would predict success working in this role. All of these individuals express very high in the emotional intelligence and have an abundance of compassion and empathy.
And Tim, there's actually a tool within the Candor Toolkit, correct, to help teams like Lisa, teams like our viewers, pick the right people.
Yeah, that's right, Marty. There's actually, when you look into the toolkit, there's a section under kind of the communication, bundle that's there that's called a communication assessment. And it's a way where organizations can send this out. It takes about 20 minutes. It's often sent out by SurveyMonkey, but you're able to actually assess people's communication skills and where do they fit on that continuum of super communicators and those that struggle a little bit with communication. The other part that we've learned as well, working with multiple hospitals, again, particularly this has been working with the Beta Healthcare Group, in some communities, some of the best people to be part of these teams are retired physicians and retired nurses who did not get this help or support, who you can then put through the training, Lisa, and then become part of your team. It's amazing because it benefits the caregivers there, but it also benefits the community. Many of these retired physicians in our research, when we went back to speak to them, said that even though they hadn't taken care of a patient in 3 or more years, being part of the Care for the Caregiver program made them feel like a healer again. And again, Marty, I think that's very important. And it goes to the whole spirit of the Candor Toolkit and Care for the Caregiver that MedStar is putting forward.
Yes, thank you. We're getting your questions. And Lisa, one of the things people want to know is how do you activate this? What triggers at MedStar the Care for the Caregiver process going into action?
Well, this is actually a very interesting part of the story. And I remember when Tim first came to Georgetown to help us set this up, he told us that this will begin as part of your safety event review program, and it will begin as an activation to a safety event. And we did. And I would say for the first year as we evolved our team, it primarily was triggered in response to a serious safety event. That has really changed, and we've evolved to where this team really now is so embedded within the fiber of our organization that it gets triggered in any event that results in any emotional trauma to the care team. And quite honestly, the majority of the trigger events now have really nothing to do with human error. It's just an event, could be the natural course of a patient's disease, but that it has led to a significant trauma to the care team.
Wonderful. And can you give us a sense of the progress that you've seen since you've implemented this program at MedStar Georgetown?
Yep, we implemented in 2014, and we actually in 2015 began tracking our performance. And what I will say is, every year we've seen a pretty significant increase in the number of times that we deploy our Care for the Caregiver team. And so this fiscal year of 2017, it looks like we're on track to touch over 400 associates by the end of this year. And a number of people on the team, and we have about 10 caregivers in total. As I mentioned, they undergo rigorous training, but we try to have enough members of the team so that no one individual team member is deployed more than a couple of times per month. And what I would say, and I'd say this to our audience, this program was a real game changer for us. And I think you'll hear Tim say that a safety program without this is not a safety program.
Yeah. Okay, we've also heard Tim talk about culture and how culture eats strategy for breakfast. Can you share some thoughts about the impact on culture or the interaction with culture because of this program?
Yeah, Tim's comment that culture eats strategy is absolutely correct. I mean, you can have the best strategies in the world, and how many times have we implemented programs that we thought strategically were very sound, but the culture was just not ready to adopt it. So what I would say is that this really truly is now hardwired into our responses to harm events and beyond harm events. And I believe that this really has demonstrated to our providers, both clinical and non-clinical, our commitment to the implementation of our Just Culture principles. I think it also serves to reinforce all of the principles that we've worked so hard at MedStar to implement around our attempt to become a high reliability organization. As Tim mentioned, one of the critical elements of any safety program is reporting of safety events. And you can't have a reporting culture unless there is that culture of transparency where your associates, your frontline associates, feel empowered and emboldened to be able to come forth knowing that sometimes they will have committed a harm event and that they are not going to be punished for it. It really does send a very, very strong message to the staff that we as an organization truly value them.
Thanks, Lisa. And for those of our viewers who want to know how you got this going at MedStar and how you keep it going, what insights do you have for them?
Well, first of all, I think everyone in the audience knows that implementation of any major initiative in a large, complex organization first requires support from leadership. And we are extremely fortunate in our organization to have complete and total support from our leadership. Then the second thing you have to do is to invite Dr. Tim McDonald to your organization as a consultant. And he visited us in 2014, and he met with all of our quality and safety team. And we received the tremendous support of the quality and safety and leadership at MedStar Health. And then we had to develop a structure. And we're very fortunate that we had already in place our Center for Patient Safety. And so this program is housed within our Center for Patient Safety. And then we set up a whole series of tactics around how the team would be deployed and set up some triggering mechanisms through, as I mentioned, hotlines. We had to identify the team. And as I mentioned, we went through a fairly rigorous process to identify team members, multidisciplinary team members, and passionate leadership. Passionate leadership of this team is, again, one of the key elements to success. We were extremely fortunate at MedStar Georgetown that we had 2 physicians, Marty, who were really passionate about this particular work product. Now, one has since left the organization, but we have an all-star leader and champion in our physician director. They undergo rigorous training, as I mentioned, and we do a lot of retraining to manage the natural turnover that the team undergoes. And then in a large, complex organization, it's getting the message out. It's getting the word out to people that this service is actually in place, alive and well in the organization. So we did a lot of messaging, a lot of storytelling, and we put together some printed materials. We've got some nice brochures, and we really have worked very hard to really operationalize this across the organization. And as I mentioned, and Tim promised that this would happen, and his promises came true, that it quickly became so embedded that most of the deployments now really are not safety events, but events that really, really do impact the caregivers.
And I remember you telling me that, Lisa, and what an aha moment that was for me, that this is not just about preventable harm, this is about trauma in general.
This is about caring for your providers.
You must have stories now about how this is playing out in your organization. Is there a story that you can share with our viewers?
I would love to. And what I would say to everyone in the audience is storytelling is probably the most effective way to really drive these principles and these projects through your organization. So I want to tell you a quick story of a patient who had an end-stage lung condition, and she'd been treated for several years at our institution. She was admitted to our hospital after a fall at home. She was on a complicated set of medications, and when she brought her medication list, and she actually came with a little brown bag full of her medications, her providers realized that one of the medications that she was on we didn't have in our formulary. And unfortunately, it was not in her little brown bag of medications. So we didn't have the medication to give her. And there was miscommunication and lack of coordination between our clinical pharmacist and our care team. They each thought that the other was going to take responsibility for getting this patient the medications. So unfortunately, she didn't get the medication, and she developed respiratory distress and died. Now, it would be very easy for an organization to say, well, this is a patient who had a terminal illness and she was going to die anyway. But we didn't. We really did a complete investigation. And we deployed the care for the caregiver team, not only to the nurses and the physicians that cared for this patient, but also to that clinical pharmacist, because he realized that it was his failure to follow policy that ultimately was responsible for the patient not getting her medications. And so we deployed care for the caregiver to that clinical pharmacist as well.
Thank you for that story, Lisa. It is powerful. And I do want to bring Tim into this. Tim, Lisa's talking about healing for the caregiver. How does that connect to healing for the family or communicating with the family?
Well, we know from the data that if caregivers are given the opportunity to be part of meeting with the patient and family at some time, sometime where it's appropriate for them to meet, but also they're ready to meet with the family. Often, their opportunity to meet with them, provide an apology if it's an appropriate response to give based on looking at the event, that can be very healing. And so I'm wondering, Lisa, from that standpoint in that case, how you guys have kind of interfaced the communication with patients and families and the care for the caregiver.
Yeah, great question, Tim. And really they're parallel processes. Because again, you've got a caregiver who realizes that their actions or inactions in this case resulted in patient harm. And yet we, out of our desire to be transparent with our patients and their families, we're asking them to interface at a very, very delicate time. So we do have support in place through our patient family communication service to provide the additional support and help that interface between the care provider and the patient and their family.
Yeah, I think that's a wonderful thing that they've done, Marty, to bring that together, because I think it does help the patients and families, but also the caregivers in that process, but in a structured way where you have people mindful and thoughtful about moving it forward.
Okay. Lisa, Tim, we have so many questions coming in, but Lisa, I know you want to share one more example that is important to share. Can you do it quickly?
Yeah, this is really one of my favorite stories, and it really brings home a couple of very, very, very important principles. One of which, and we spend a lot of time with our associates messaging this, that sometimes these events don't actually necessarily have to be clinical events that impact patients or families. So this story really involved one of our environmental services workers. And he is a 70-year-old gentleman, previously healthy, was in an 8 a.m. staff huddle when he began exhibiting slurred speech and some weakness of an arm. One of his coworkers immediately identified in this gentleman signs and symptoms of a stroke and proactively activated a stroke code. But then quickly realized, because of where environmental services is located in our hospital, they're in a relatively remote location, the team began very, very concerned about the possibility in the delay in treatment, knowing that with stroke patients, every minute counts. And so they came together, and working as a team, they interlocked their arms and created a human stretcher and transported their colleague physically to the emergency room. They carried him to the emergency room where he underwent emergency assessment and intervention for an acute stroke. and miraculously he had a complete recovery and left the hospital 4 days later. Now, of course, this was a great outcome and nobody was really harmed, but the truth is, having witnessed one of their own go through this event was very traumatic to the team. So we deployed our Care for the Caregiver team not once, but a multitude of times across the day to make sure that we hit all of the affected workers.
Yeah.
That's an amazing story.
Yeah.
It is.
And how well you've hardwired it, you know, at MedStar Georgetown.
Yeah.
I mean, that's just a great story to show what can happen.
Yes,
That's
it
terrific.
is.
Terrific.
Okay, so thank you, Lisa. Thank you, Tim. Before we go any further, we have to get our audience involved because you've been sending in some great questions to us. Let me start with the one that's come up quite a bit. It's the connection between this and liability risk. People want to know how you protect the conversations that you're having from discovery and the impact on liability risk. Tim, why don't we start with you?
So you're, I'm assuming you're talking about the Care for the Caregiver conversations.
Yes.
And so what those are conversations where you're providing emotional first aid to the people. You're not talking about the facts of the case. And I can tell you, working with dozens and dozens of hospitals and talking to Joe Shapiro at the Brigham as well, this is an issue a lot of people worry about, but it hasn't come to fruition, particularly if you don't get into the real factual conversation about the event. This is like them talking to anybody in a coffee shop. Hey, here's what happened to me. I'm feeling bad about this, and supporting them.
Tim, the specific question, though, is that conversation protected from discovery?
Well, it wouldn't be protected from discovery, but you're not saying anything in there that would be of need to depose or get information from, because you're not talking about the facts of the case. You're talking about the emotion. I mean, theoretically, anything that's not protected or privileged is something that somebody could subpoena or try to get information on.
Okay, great. And do you want to speak just a little bit, too, about liability risk in general? As we implement programs like this at MedStar Georgetown and elsewhere, what has the impact on liability risk been?
Well, again, I mean, if you look at our data, and of course, the first couple of articles that came out, you know, Craman's work at the VA very early on showed that being extremely honest does not increase liability costs. And then, you know, Rick Boothman's amazing work at Michigan showed the same thing. And we were able to duplicate a lot of that at the University of Illinois. And since that time, a whole lot of other work has been done, Marty, showing open and honest communication does not increase claims. It does not increase the cost to your self-insurance or your insurance program. And I think that's one reason why the Beta Healthcare Group and Insure is incentivizing their organizations to put this kind of program in, because they know the data.
Okay. We have another question about an issue that I think is connected, but help our viewers connect it, and that's the issue of apology. How does the communication with the family, the communication with the caregivers interact in hospitals that have a commitment to apology?
Well, so, I mean, it is critical that when you've made the determination that care is inappropriate, provide an apology. And I think, Marty, at this point, it's good to distinguish empathy versus an apology. An apology really is when you go in and say, hey, we made mistakes, and these mistakes hurt you, and we own it. And that's important because empathy, you should provide everybody. In other words, we are so sorry that this happened to you. Apology should only been given when you've had a very thoughtful, mindful process to really assess the fact that your care was inappropriate, like Lisa described. And so it's important to know the difference between that.
Yeah.
And we, at MedStar Georgetown, as I mentioned, we have trained our patient family communication service. And they are, as Tim mentioned, very, very thoughtful conversations. They're scripted. We are very, very careful that we understand what it is that we want to communicate to the patients and their families. And we're there to support the clinicians in having those conversations. MedStar has really, I think, been way out in front on transparency and honesty, open and honest communications very, very early on with patients and their families.
Okay, thank you. We have a question also about remuneration. Is there any special remuneration or payment that goes to members of your caregiver team? It's a question to you, Lisa.
Yes. So at this moment in time, this is a completely voluntary activity. We do not financially reimburse our providers who give of their time. As I mentioned, we've got a couple of highly invested individuals who probably do about a third of these events, and the rest are distributed fairly equally amongst the other members of the team, so that no one individual is, we want to make sure that no one individual, because everybody has their day job, that no one individual is having to assume more than their share. But at this moment in time, we do not financially incentivize our providers.
And Tim, you found that to be true in your other clients too, that the work gets distributed, correct? And has this payment issue come up?
Well, it does, and I agree with Lisa. Most of the people who are actually going to do the providing the care for the caregiver, these are voluntary people. You know, these are docs and nurses who want to do this. In fact, many of them will speak to the fact this brings joy and meaning back to their work. Occasionally, we'll see organizations buy out some time for the person who's going to lead the program. So if that's going to be a 0.2 or 0.4 FTE, Lisa, that's where I've seen some organizations actually give that person that time to really run the program.
Yeah, thanks, Tim. And we do that at MedStar Georgetown. Our physician director of this program we have bought out some of her time to support her work in this.
Okay. We've got a lot of questions about where to get the toolkit, and there is a link to the toolkit in the chat box section, so do check it out. Lisa and Tim, another question we're getting, it kind of gets to your last story, Lisa. Can anybody in the organization trigger the care for the caregiver team, and how does that work? And I mean, does the word get out in an organization when you go in and work and build this kind of culture?
Yeah, obviously when we first implemented this, we had a lot of discussion around, who is going to trigger this, how is it going to happen, and so we've made it as easy as absolutely possible to trigger this. We have a phone, a hotline that gets answered. We've got a pager 24/7. Absolutely anybody, including patients and their families. We have, as I mentioned, we put together a very nice brochure that outlines all of the activities of the team, the purpose behind the team, and we have distribute it widely throughout the organization. I don't know that we've actually had an event that was called or triggered by a patient or their family, but we've certainly had it triggered by a wide spectrum of people within our organization.
Of staff. And Tim, you mentioned Beta Healthcare, but we also have one of the HINs that has been very, very diligent in rolling this out across the organization. That's Dignity. If you think about Dignity, Beta, or some of the other organizations that are early adopters of this, what are they finding? Are they finding the team being triggered by multiple levels of employees or patients, as Lisa mentioned?
Yeah, and they have, Marty. So speaking of Dignity, who we've worked with a lot, where they have really rolled this out in many of their hospitals, particularly in the Sacramento area, they actually call their team, Lisa, they call it the We Care program. And it's capital W, capital C, all one word, We Care. And Marty, what they've done is throughout the hospital, they have posters all up everywhere, the number to call, and they do have people activate it, where they call the number. And they did something clever with all their hospitals. They actually have a regional care for the caregiver approach. So it goes into a regional area who can then parcel out the people to do that, Lisa. So when you have a bunch of hospitals in a system, one efficient way to do it is to create a regional place where they're able to push it out. And amazing stories that Linda Ubaldi and others are able to share from Dignity, Marty, from that standpoint.
Cool.
So.
Okay, thank you. We're getting a couple of questions about research too. We've shared some statistics with the audience today, and some stories about the experience. But as we think about growing this and helping our viewers grow this, are there more research needs out there? Is there more research going on? Tim, do you want to talk about this? You've been part of what we've learned so far. What else is on the horizon there?
Well, so I think that, Marty, again, we talk about that it's the right thing to do this, but often we need data to convince people it's the smart thing to do. And what's the ROI if we're going to do this? And so I think the research, Marty, is going to be, is it working to the extent we want it to, what we want it to do, which is, does it bring more joy and meaning to the workplace? Is it something where we have, less burnout in terms of measurement that we have there? And are people practicing safer care? Because, they are getting this kind of intervention. There's ways to study that. And I think those are just a few of the ways where I see the future research may be going to look at this, so that like we did with the Candor Project on the financial side, on the liability side, I think we're ripe now to do a lot of research in this area. And MedStar is going to lead that, because obviously they have a huge research center as well focused on patient safety, as we know. And I'm looking forward to the outcomes that they'll see from that.
And I love the connectivity between this work that you're leading and doing and the Join meeting in the workplace, because as we know, we're hearing more and more about that.
Yep.
Sadly, we've reached the end of our program. And it's been a great program. We could talk about this for a long time. But we hope it's encouraged you, our viewers, in your efforts to provide support to the caregivers in your organization. And thank you so much for your questions. Lisa and Tim, thank you for sharing your insights with us. It's been a privilege to have you on the program, and thank you for taking your time joining us today. Thanks also to the Vizient HIN for their ongoing support for this series. If you've registered in advance, the program evaluation will be emailed to you. Please take a moment to complete it. And also, please mark your calendars for the next web broadcast in this series, which is on Wednesday, June 22nd. It will be entitled Diagnostic Errors, a new chapter in patient safety science, policy, and practice. It will follow 2 interactive webinars that will approach this topic in depth. So please check the schedule for the HIN Community Knowledge Network series to find the dates and times of those webinars. And now from Vizient, I'm Marty Hatley. Thank you so much for watching, and have a great day.